Many thanks. Good morning, everybody. Thanks for coming today. I thought it would be interesting today to put a surgical and anaesthetic slant on my talk to give you an idea of how we deal with the problems of men's health in the environment of the prostate centre. I should wish you a belated Happy Ether Day, because last Sunday, as you well know, the 16th of October, was the commemoration of the 165th anniversary of the first anaesthetic, which was ether, of course, in Boston. Hope you all celebrated. About 18 months ago, this document was produced by the NHS regarding the delivery of enhanced recovery. Enhanced recovery was a term produced to take over a little bit from fast-track surgery, which you might have come across. And the whole concept of this is to really get patients through a difficult time going into hospital for an operation as quickly and as smoothly and as safely as possible, and emphasising improved outcomes, avoiding all the difficulties and comorbidities which occur during surgery, and getting back to normal life, as a patient would describe it rather than we would, getting back to work, getting home, and getting back to everyday activity. It's very patient-centred, puts the patient right in the middle of everything, and it's highly proactive. So from the word go, the patient is heavily involved, and this is something I've been very for a long time now. There's a Professor Kellett from Denmark that many of you will have come across. He's a professor of surgery, but to his credit took on a huge perioperative role, and over the last decade really has produced fast-track surgery as a very real entity. And what he did was really to challenge tradition and habits which we have been taught and used throughout our careers, and said maybe we don't have to do it that way. So we can make things better by changing the way we do things. It's really a team approach, and so right from the beginning of a patient consulting with his GP, he will immediately get referred to specialist care, but that specialist care won't just be perhaps the surgeon doing the procedure, but somebody like myself, an anaesthetist, will also be a physiotherapist, will also be a nutritionist potentially, and specialists. More and more we ask for a cardiology opinion, a respiratory opinion, an endocrine opinion. So we take the opportunity of the patient presenting with a complaint to give them a bit of an overhaul. And so men's health, from my angle, is latching on to urology as a very suitable point to pick up men of an age who turn up with a urological issue, but hey presto, they've got so many other issues going on as well. So enhanced recovery is a planned and anticipated procedure. So right from the off, we set the dates, we set the program, and I'll give you an example in a while. But most importantly of all, the patient is in the middle of all this activity, and they will be fully averse of everything that's going to happen. They will get lots of written information and plenty of time to discuss what's likely to come ahead. So just to use, as an anaesthetist, I would use this typical scenario of pre-op, per-op, post-op to talk about the whole perioperative procedure. And I just want to focus primarily on the pre-op area. In other words, what do I do that helps a man get through typically prostate surgery, as an example? A little word on per-operative care, which is a bit more detailed, and specialists, not really necessary here. And some thoughts on post-operative care as well. The whole principle, remember, of fast-track surgery, enhanced recovery, get home, get well, ASAP. What can we do? The media's full of all of these types of reports which talk about obesity very regularly, obesity in children, obesity in teenage girls, obesity in an adult population. Smoking is frequently visited, and of course alcohol consumption, as we'll hear later. All of the topics that Roger introduced will keep coming back during the day, because that's the whole of men's health encapsulated. But obesity I would rate very highly, because as an anaesthetist, looking after people with complex surgery for cancer of the prostate and robotic radical prostatectomy, I really need these guys as fit as possible. Whole principle of enhanced recovery is to get the patient to join you as the team caring for him. Here's the slide again that you've seen. We're aware of the cardiovascular risk. We're aware of the 5-fold increase in type 2 diabetes. And we'll come back to these repeatedly today, I'm sure. The cancer risk ×3. So very often when I meet a man for a radical prostatectomy, which is my primary practice, he is overweight and even obese. So that's an area that I want to focus on very quickly so that his recovery is enhanced. The American Heart Association just a month ago came back again and said that waist circumference and BMI are very valuable measures. I put this in because too often we see, and we've already seen a few today, big fat tummies. We get a little bit saturated with that image of overweight men overeating. How do we measure that disability? BMI, well, it's been around a long time. It can be misleading. Oh, waist circumference, well, that's also misleading, depends on your body build. But actually, here we are, once again, only a month ago, I'm happy to see underscoring the importance of, in particular for me, waist circumference. So the enhanced recovery example that I'm taking you through, for me, really is all about coming in fit. From the time I meet somebody, I may have several weeks from their diagnosis to the actual time of surgery. As I've suggested with enhanced recovery, we know the date of surgery immediately, we know who's involved, and we have time, we have weeks in which to prepare. I recently ran the Berlin Marathon last month, and I didn't turn up on the day hoping to finish, because that would have been pretty futile, but I tried my best to prepare. And I give that example, and I ask these men to consider their operation as a mini event. And they really do need to prepare for it. Simple measures, they're listed there. I'm a particular fan of the 10,000 step program because this is an ancient Japanese tradition, really, whereby one should never go to bed without having taken those 10,000 steps. I like that number on that particular pedometer. And pedometers now can be purchased for ridiculously little sums of money, £2, £3, and they are incredibly valuable. You would be amazed at how little we or our patients walk in a day. Couch potatoes in a study in New York were doing as little as 1,500 steps a day, which is just complete inactivity. And of course, with a great big plasma screen and a big computer screen, you don't really need to leave your home or work. So my argument is, let's get out there. How many people own trainers and sportswear? Again, I have to emphasize to people that I really want them to get into the mode of physical exercise, and I'll define what I mean by that shortly. But it isn't necessarily gymming in Lycra, very rarely, in fact. Coming back to fast-track surgery, synonymous with enhanced recovery, we need a care plan. More and more hospitals are producing integrated care pathways where we don't see the patient daily and think, what should we do today? We have goals and targets. Staff training will expect these changes on day 1, day 2, day 3 post-op, and the patient's own expectation is that I will go home tomorrow or the day after. So we're working towards goals, terribly important. Men are goal-directed creatures. Really need to know, and I hate running marathons, but I did it because it's a goal, so I had to train for it. We're constantly trying to break down traditional practice and habit, whereby we just feel our way along. We no longer need to do that. Here are a few items which make fast-track surgery a success. Does it matter what day of the week the operation is? Well, the evidence is that on a Monday, you're going to get better looked after post-operatively than on a Friday afternoon because it's the weekend. So that's very relevant. Makes sense, but do we allow for it? Communication lines, what's that like over the weekend? Are the whole team involved? Even the time of day. This morning I was doing a ward round and I learnt of a laparotomy late at night around 8:30 last evening, which finished at 2 a.m. this morning and involved some of our team. So they're out of action today. So can we plan things a little better? Rotas, etc. Shared decision making, of course, as I've said, making the patient responsible. The one in the middle, early mobilisation. There's no reason we can't get patients up the same day or at least the next day. Remember, the fitter the man is when he comes in for this operation, the more amenable they are to these things. Of course, technically, we've got loads of clever things going on, and you'll hear some of those today as well. We've got less invasive surgery. We have robotics. We have keyhole. Pain relief has come on unbelievably so. It was only 15 years ago that pain relief after surgery, a report published, suggested that pain relief in the UK was Victorian. And it was really just IM morphine, intramuscular morphine. It's not going to get our patients up and going quickly. Patients were never told about pain and they never prepared for pain. So a whole different way of practicing medicine. Let me give you an example. A typical man, say 62 years old, I met earlier this month, with early gland-confined prostate cancer, raised PSA, heading for surgical removal of the prostate. His weight at the height of 1.70 meters was 94 kg, 94 kilos, body mass index well over 30. Random blood sugar, or even a fasting blood sugar, was above 8, which was unrecognised. And lipids were well over 6.4. Most of the lipids, of course, were LDL, very little HDL there, so plenty of room to improve things. Blood pressure, excessive, and from my point of view, left ventricular hypertrophy, left axis deviation, and potentially impaired cardiac function. Liver function tests we'll hear lots about shortly, but again, often alcohol is part of a man's regular living and often taken late at night. Lifestyle, I always quiz my patients about lifestyle. Do they walk to work? Do they take a car to work? What are their eating habits? Typically, and this chap was no example, no breakfast, big mistake. Lunch on the move, which was a sandwich. Sandwich is bread and butter and something fried in the middle. Pretty disastrous nutrition. And exercise, the usual answer is I used to exercise a lot, but currently there is none. So lifestyle modification for me is about getting those men ready for major surgery, but it's also a great opportunity to get these men and improve their health standards. So everyday life, lifestyle activity for me refers to things like not taking the lift, Roger mentioned, perhaps walking to work rather than taking the bus, perhaps getting off the tube a stop early. These are lifestyle changes. However, and they're good, and we encourage them all the time, but exercise, as we've heard, is necessary every day. I would also agree that twice a day would be the ideal. It's tough to maintain. But exercise is a planned thing where I say to the men, you would be wearing something different. You would not be wearing a shirt and a suit. You would need a shower afterwards, and I would expect you to get hot and sweaty. Nobody wants to do that on the way to work or climbing the stairs, so you slow down. So I regard lifestyle and exercise as two very, very different things, and they need defining. It's also important to remind men generally, not always, but they gain weight with middle age and beyond. So it's time to address these issues. And of course, it's an insidious problem which lifestyle can address. Here's a few numbers that if we increased our intake by a mere 50 calories a day, that's a slice of bread or even an apple, every day, we would put on 2.5 kilos in a year if we didn't change lifestyle. I'd also remind you that a kilogram of fat is worth 9,000 calories, kilocalories. And if you run a marathon of 26.2 miles, you'll only burn 6,000 or 7,000 calories. So really, that's a huge energy resource. And if we're carrying a lot of energy with us, it's highly unlikely we'll remain fit and well. The good news, though, is that losing a kilo a week only requires us to cut down 500 calories per day, every day. And that's a fantastic profile. So how do I get these pre-operative men to cooperate? Well, I use the enhanced recovery program. I use the idea of fast-track surgery, and I appeal to them and motivate them that they should get ready for this event. Of course, reactions will vary, and one has to be careful, but I have the advantage, perhaps, over many primary care doctors in the sense that they're all ears, because I will be looking after them. So I would like to see anaesthetists use this role much more willingly to get men on board, agree the goals, agree the dates, and aim for something like a 5 to 10% reduction per week. Very realistic, and we do it all the time. Physical literacy is something that is lacking. Physical wellness and physical exercise is something that should be known about. We had a very valid comment just earlier from the audience saying that, you know, this education should start from square one, really. And it's just not there. The motivation is low because it hasn't been highlighted. Physical competence, it doesn't matter if there's a weakness in the ankle or a disability of some sort, there's always something we can do. So upping the understanding and realizing that exercise is as necessary as water and oxygen to our well-being. There are lots of barriers to change, and you've come across all of these, I'm sure. I don't have the time, I just couldn't do that, doctor, I couldn't walk. You know, I've got a bad ankle, a bad knee, my back, heard it all. Low self-esteem is often high up in there, that, you know, you couldn't face putting on sportswear for fear of being taken not seriously. So somehow we have to motivate and get the assertiveness up. Staying with the idea of enhanced recovery, which is what this is all about in my practice, there are lots of things we can do in anaesthesia that have changed beyond recognition. Carbo loading, how many patients used to starve for so many hours, if not a day or two, before their operation? Completely pointless. Now, just like me before running a marathon, carbo loading is recommended. Hydration is crucial. You only need 2 hours nil by mouth for water. So why starve patients all day long until a late afternoon operation? The nil by mouth rules have changed completely. Bowel preparation, which was a terrible purgative to dehydrate and upset the gut and the physiology and electrolytes, has gone. We rarely use a bowel preparation. And we don't give nearly as much intravenous fluids as we used to. All of these tactics make a patient better, quicker, and out of hospital. Opiates, which were the mainstay of most anaesthesia, have now been very much reduced. And the drug I've listed there, remifentanil, has a half-life of 3 minutes. So I can stop it and start it at will, but I'm not relying on it. There are pieces of equipment which you will have heard about, but the detail don't matter. The esophageal Doppler has been singularly helpful in managing patients in this new way. Of course, the risk of thromboembolism is high, 25,000 deaths a year in the UK. So lots of new techniques come along to manage that. Obesity, of course, and ill health and immobility underlies those. Of course, we're using lots more local and general anaesthetic techniques. Here are a couple of pictures just to show what an esophageal Doppler does, and I can measure cardiac output in a completely non-invasive way. And it's changed, for example, me typically giving 4 or 5 litres of fluid down to maybe giving 1 or 1.5 litres of fluid. It's that significant. So a very, very valuable, simple, and I'll just highlight the last comment there, no complications reported to date. So there are ways of looking after men with complex surgery which are very sophisticated, but still not as important as their own preparation. Here are some things which in fast-track surgery have been changed radically. We take away drips as quickly as possible. We eradicate traditional practices and ask, why do that? Why leave a patient in bed? Why don't we feed them? Why don't we give them oral fluids? Why are we leaving that drain in? And do we ever need a nasogastric tube, for example? We're challenging everything to good effect. Key factors, again, are keeping a patient warm. We use epidural anaesthesia and we use local anaesthesia to block the stress response to surgery, which is very detrimental in the post-operative course. But again, I emphasize the fitter a patient is when they come for surgery, the better everything goes. I can get all the drips and tubes and pain relief off the menu if they're fit. It really is like winning the lottery if they prepare for that operation. More details really about pain relief, but intravenous paracetamol has been an incredible way forward. So we can offer painless surgery using all sorts of different techniques other than opiates. Patient expectation, very important. Here's a typical list of what fast-track surgery involves. We've covered most of them. I would just beef up the good pre-assessment because there I think there should be cooperation and preparation by the patient, not just the team. But this is a typical scenario, and this is being introduced both nationally and internationally right now to very good effect. So really it's a team approach, and working together with GPs, regularly speaking to GPs directly. I would love it if anaesthetists spoke more with the primary care doctors because we are your representative in the hospital, really, and the teamwork can produce much, much better results. Here's a very large, lardy anaesthetist called Amoroso in a former life. BMI 40, weight 123 kg, struggling at the end of the day to stay awake. We can change our lifestyles. Here's a better version, running fit, running strong. I've avoided all the horrible things so far that we're going to talk about today. And so I think the message has to be spread loud and clear. Men have to take their health seriously. Thank you.